Hi, my name is Madison Shaver. Me and my group have decided to do cervical cancer with the intervention Keytruda. So first, we'll talk about the biology of cervical cancer. Starting with the tissue and cell type, cervical cancer begins on the surface of the cervix, which is just a lower portion of the uterus, and it starts in the epithelial tissue. There are three tumor types or subtypes, starting with the first one is a squamous cell carcinoma. It is the most common type, um, and most of these originate where the cervix joins the endocervix, which is also called the transformation zone. Up to 90% of these cervical cancers are squamous cell carcinomas, showing that it is the most common. And then the picture to the right is a histology diagram of one. The second type is an adenocarcinoma. The cancer that develops from granular cells. In cervical cancer specifically, they originate from mucus producing gland cells in the endocervix. And then the last type, type 3, is when there are features of both the adenocarcinomas and squamous cell carcinomas. When they are both present, it's much less common, almost rare, um, but these are called mixed carcinomas. Thank you.
Hello, I'm Angeli Suarez, and today I will be talking to you guys about some tumor suppressor genes and proto-oncogenes affected in cervical cancer. HPV is one of the main causes of cervical cancer, and once the virus's genetic material is integrated within the epithelial cells of the cervix, it will express viral proteins such as E7, which inhibit the retinoblastoma protein. Retinoblastoma is a tumor suppressor gene, and its main function is to inhibit transcription regulators by wrapping itself around them. By inhibiting transcription regulators, retinoblastoma can suppress the expression of genes that allow for cell proliferation. Usually, retinoblastoma is inactivated by cyclin-dependent kinases during the G1 S phase and S phase restriction checkpoints. These CDKs respond to mitogen signals and phosphorylate retinoblastoma. Once phosphorylated, it will be inactivated, allowing for transcription regulators to become active. Now these cells can continue on through the cell cycle. With HPV, the overexpression of the viral protein E7, it can interact with the tumor suppressor gene retinoblastoma and inhibit its function. So now tumor cells don't need to rely on CDKs to proceed into the cell cycle and proliferate. The hallmark accomplished here would be evading growth suppression. Another protein produced due to HPV is E6. E6 can inhibit the tumor suppressor gene P53. P53 detects cell damage and arrests the cell cycle or induces apoptosis. As we can see, an activated P53 acts as a transcription factor for the P21 gene. P21 can in turn inactivate the G1S CDK and SCDK complex and arrest the cell cycle at the restriction checkpoints. When the E6 protein is produced, it can degrade P53 and therefore reduce its function. By doing this, tumor cells can enable replication, evade growth suppression, resist cell death, and have genome instability and mutations that go undetected. The last thing I want to say about HPV is that it is not heritable, but it is spread by skin-to-skin contact. Now that we have talked about some of the tumor suppressor genes affected, let's go into our targeted therapy of choice, which is pembrolizumab, also known as Keytruda. Keytruda targets programmed cell death ligand 1. Now in pink, we see a T cell, which is an immune molecule that expresses these PD receptors. It will go around and bind PD ligands in normal cells. These ligands basically tell the T cell not to alert the immune system. In cervical cancer, the oncogene for PD ligands is overexpressed. So when these T cells arrive, they bind the ligand and the tumor cells go undetected. The hallmark gained here would be evading immune destruction. Keytruda is an immunotherapy, and it has antibodies that will bind to the PD receptors on the T cells. Now the PD receptor cannot bind to its PD ligand, and it will alert the immune system. And that is all I have for you guys. Thank you.
Hi, so I'm Lindsay. So I'm going to be talking about the public health issue with cervical cancer. So I'm going to start off by talking about the current incidence and prevalence rates. So the incidence rates are the new cases, and the prevalence rates are the cases that already exist. So the current incidence rates of cervical cancer in the United States is 11,500 people have been diagnosed with cervical cancer in the last time the statistic was collected was in 2020, and it accounts for 0.7% of all new cancer cases in the United States. And the rate of new cases has continued to decrease over the last 3 decades, with rates from 11 out of every 100,000 people to 6 out of every 100,000 people. And that can be due to different screening techniques that are now out there. So like the main one is a pap smear for those who are biologically female and go to their annual gynecology appointment. So the mortality statistics of cervical cancer is over 4,000 biological females die from cervical cancer each year, which accounts for 0.7% of all cancer deaths. And mortality rates have slowly declined over the past 3 decades, with the death rate being at 4 out of every 100,000 people. And then that has now decreased to about 2 out of every 100,000 people in 2020. So you can see that statistic, that those curves have started to decline. And these statistics are in the United States. So the variations by person, place, and time. So on here, you can see that the darker the colors are, the more incidence rates are. So the amount of new cases that have been calculated. So in 1999, you can see that the cases are much higher than the incidence rates in 2020. So again, incidence rates are new cases. So in regards to person, by gender, the disparity only affects those with a cervix. So those that were assigned female at birth are the only people that are at risk of developing cervical cancer. So there's not any type of statistics comparing biological females to biological males, since biological males cannot suffer from cervical cancer. And then by age, women that are between the ages of 40 to 44 are at the highest risk of developing cervical cancer at a rate of 14.2 out of 100,000 people. And women that are between the ages of 20 to 24 are at the lowest risk of developing cervical cancer at a rate of 0.4 out of every 100,000 people. And then by race and ethnicity, women that are Hispanic or American Indian / Alaskan Native are at the highest risk of developing cervical cancer at a rate of 8.4 out of every 100,000 people. And women that are Asian Pacific Islander are at the lowest risk of developing cervical cancer at a rate of 5.4 out of every 100,000 people. The highest incidence rates of cervical cancer by place, the last time the statistic was collected was in 2020, and that was the highest rates are in the southeastern region of the United States with Oklahoma. So you can see on this map right here, Oklahoma is the darkest color. And the number of new cases in Oklahoma was 9.7 out of every 100,000 people. But generally, over time, incidence rates have drastically decreased, and those are due to new screening methods. So it's more of a mass screening method. So those that do go to their yearly gynecologist appointment are being screened for cervical cancer and other issues. And then in 1999, the state with the highest incidence rate was West Virginia. And then again, over time, incidence rates have decreased by about 54% from the mid 1970s to the mid 2000s, and that's due to mass screening of cervical cancer in those who were assigned female at birth. And then the observational study that I found was a cohort study, and this was a retrospective cohort study. So they had all of the participants and they were looking at them at one point in time, but looking at them in the past. And it was conducted in 2007, and it consisted of a little over 3,000 women, and it discovered that smoking was not an independent risk factor for cervical cancer, except for those that were high risk for HPV. So those that may not have received the vaccine or engaging in other risky behaviors. And it determined that smoking had a direct relationship with those who were already HPV driven to developing cervical carcinogenesis. And the strengths of this risk factor is those who are born female and smoke cigarettes are at an increased risk of developing cervical cancer due to changes in the cells of these individuals. It increases their risk of developing HPV, which is already a known leading cause to developing cervical cancer. And although the study conducted did not formulate too many conclusions on the correlation between cervical cancer development and smoking, it was important for researchers to continue researching this topic and take into account the confounder of smoking in all cancer research. So a confounder is like a variable that researchers need to think about when they are doing these studies that can account for a different outcomes. So like some other confounding variables, examples are like race and ethnicity, gender, which in this case, it's all those who are biologically female. So that's not a confounder in a study like this. So just keeping in consideration that there are different things that play into people's health. And then this study was useful in finding the prevention of this, or for finding the prevention of cervical cancer, because it determined that smoking does increase the prevalence of HPV, but there was no direct correlation between smoking and cervical cancer diagnosis. It did determine that there is a clear link between HPV diagnosis and cervical cancer, and that those who smoke are at a higher risk of developing cervical cancer. And the researchers did not find a clear, so the exposure in this study was smoking and the outcome was cervical cancer.
So now we'll talk about the efficiency and side effect profile of Keytruda. First, with the efficiency, with the addition of Keytruda to chemotherapy, improved the overall survival rate and progression-free survival, showing that there is more positive than negative impact. The side effects, however, include abnormal liver function, tolerable hepatic dysfunction, neutropenia, decreased appetite and fatigue, and fever. The three with the asterisk beside them are the most prevalent or the more common side effects. Then in my research, I found a meta-analysis. This analysis gives us many statistics to help understand the efficiency of Keytruda. In this analysis, there were 727 patients, with one study that had phase 3 RCT, 4 studies that were phase 2 RCT, and one study that was phase 1, and then they added in an observational study as well. All of these studies were published between 2017 and 2021. 6 of them used the monotherapy of Keytruda, and then one study used a combination therapy, meaning that they used Keytruda along with other things as well. This is a table just kind of giving the data from the analysis. We have the authors and then their year of publication. Then the phases, unless they did an observational, that one is said there as well, with the number of cases, where it was taking place, and the tumor stages. That table kind of gives us the statistics from the analysis. So the complete response rate of treatment was 2.7%. The partial response rate was 10.4%. The rate of stable disease was 19%. The disease progression rate was 54%. Objective response rate was 15.5%. Disease control rate was 33.1%. The median overall survival was about 10.23 months. The median progression-free survival was 4.27 months. The best response time was 2.1 months. And then the 1-year death rate was 38.8%. The total incident of side effects of grade 3 or above was 21.2%. This mainly includes those 3 side effects that had the asterisk beside of them, including the abnormal liver function, fatigue, fever, those kinds of things. This table continued kind of going back to the subtypes and tumor types. So it gives the authors the years, and then it breaks the patients down into whether they had squamous cell carcinomas, adenocarcinomas, or a mix of both. And then a few of them had a couple other things as well. As you can see, the squamous cell carcinomas were the most common. But that gives an overall the statistics and data from this analysis showing the efficiency of Keytruda.
Hello, my name is Tao, and I'll be discussing specific aspects of the clinical research in cervical cancers, having 2 objectives in mind. The first being to describe the clinical course of cervical cancers, along with the average patient experience on the targeted therapy Keytruda, which brings us to the second objective, which is to describe the rationale behind the development of Keytruda. Now, cancers are defined by the cells they arose from, and there are three main clinical subtypes of cervical cancers. The first being squamous cell carcinomas, developing in the squamous cells of the ectocervix, which is the outer portion of the cervix, here highlighted on the bottom. The second are adenocarcinomas, which develop in the glandular cells of the endocervix, which is this inner portion of the cervix highlighted here on the top. And finally, adenosquamous carcinomas, which have a combination of both squamous and glandular cells. But this is the rarest of the 3 types, with squamous cell carcinomas being the most common. And as Madison mentioned previously, about 90% of cervical cancers originate from squamous cells. Early stages of cervical cancers exhibit better prognoses in comparison to later stages. This is partially due to the availability of primary and secondary prevention methods, such as HPV vaccines, pap smears, and HPV testing. But what if you don't have access to regular screenings and or vaccines? This is where the burden of the disease lies heaviest in low to middle income countries, with concentrated incidence and mortality rates in Africa, Melanesia, South America, Southeast Asia, and also South Central Asia. And this is due to the fact that women who face financial issues and or who lack health insurance are less likely to get regular screenings, preventing the possibility of either early diagnosis and or treatment. Now, this is a very lengthy list of the different treatments and procedure combinations based on disease progression or cancer stage. But I want to draw your attention specifically to the recurring cervical cancer stage here at the bottom, because this is where our chosen targeted therapy comes into play. And I also wanted to share the recent finding in late 2021. Keytruda was approved for first line or the initial treatment of cervical cancers. And this consisted of the targeted therapy Keytruda combined with chemotherapy administered with or without the drug bevacizumab. But as far as average patient experience goes, Keytruda has tolerable toxicities when administered alone, but off-target effects increase with combinational therapies. bringing us to the second objective, which is to describe and explain the rationale behind the development of Keytruda. Now, Keytruda itself is a monoclonal antibody that blocks the PD-1 receptor from binding with PD-L1, or the programmed death ligand 1. Now, normally PD-1 functions to prevent T cells from attacking cells from the other parts of the body by attaching to PD-L1. And this interaction ensures that the cell is safe from immune attacks. And Keytruda counteracts this by targeting and blocking the PD-1 pathway, which further blocks the binding of PD-L1 to PD-1, thus exposing more cancer cells to immune attacks because they can no longer hide. Now, again, Keytruda is a monoclonal antibody, and antibodies have specificity. They're used as honing devices to find cancer cells and administer extremely toxic and high doses of a drug, in our case, Keytruda. And in our case, the antibodies find cells with large amounts of PD-L1 and then targets, again, the PD-1 pathway to either shrink or slow tumor growth. Common side effects include hypothyroidism, decreased appetite, fatigue, nausea, and several more, but these are some of the ones. Now, Keytruda, again, has tolerable toxicities, but it's also known as a targeted therapy, which are also known to affect cancer cells more than it affects normal cells, which cannot, the same cannot be said for conventional therapies, as they lack the ability to differentiate between normal and cancerous cells. And that concludes our second and final objective of clinical research in cervical cancers. Thank you for